we're going to pop some links in the chat as we go through in terms of things that we make reference to. We'll obviously try and put the links in so that you can then it'll signpost you to what we're actually referencing. So if we just move to the next slide then, please. That would be great. Lovely. So you can see today's agenda then, that's obviously been circulated and sent around to you all as well. You'll notice the chat function is enabled. We want to hear from you. Obviously there'll be the opportunity to ask questions to each speaker at the end of their slot, and the Q&A at the end as well, but please do be posted into the chat as well. We will, as always, collate that Q&A document for you and make sure that we've got the responses in and that we publish that alongside the slide packs and the link to the recording for you all as well. So just a gentle reminder then at this point to remain on mute then, unless you're the speaker that's speaking, or we then go to you to ask a question. So looking at today's agenda then, Marina and I will start with the officers update, and then obviously we've got HQIP following on as per usual. Then we've got Stuart Monk, who's the National Programme Director at the Health Innovation Network, who's coming to talk to us today about the MedTech funding mandate, and then NICE will be joining us for that strategic update later on before we finally move to the Q&A and then we close. So if we just move on to the next slide, I think that should start to see us with the officers update. Fantastic. So we'll immediately move on to the next one, please, then Marina. So before we launch into our officers update, it's just to let you know that we're at that point in the officers terms where we'll actually be going out for expressions of interest for General Secretary. Marina will have completed a 2-year term as of October and November this year. So as per our NQICAN governance arrangements, we're just announcing that we will obviously over the summer be going out for EOIs during July and August, with the election taking place in September. So watch this space. If this is a position that you're interested in, you want to know more, then obviously do get in touch. Marina and I are more than happy to have a chat about the role, and then obviously being an officer for NQICAN. Please do go back and discuss these opportunities back within your organisation, maybe as part of your appraisals, and maybe consider submitting an EOI. And obviously great opportunity to Marina to thank you for all the great work that you're doing already within the General Secretary role and obviously Deputy Chair of NQICAN. So more information to come out, but we're just giving you the heads up today to expect that EOI process to be taken forward during July and August. So if we move to that next slide then, I think we start our officers update. Fantastic. So this last quarter then, since we met with you in March, then we've been really busy with the support in the run up to Clinical Audit Awareness Week 24, which is obviously 24th to 28th of June. It's this month. And HQIP will talk to you a little bit more about that. And obviously we've got a few slides later on in our update for you as well. So we've continued with our regular meetings, catching up with HQIP, and then obviously our regular steering group meetings where we're undertaking that operational work behind NQICAN. We've reviewed our network and sharing platforms, the forum and the National Clinical Audit Knowledge and Learning Hub on the Futures platform, and we're going to touch on that shortly with you today. Obviously, on behalf of NQICAN, we've attended some further specification development meetings where national clinical audits are up for recommissioning. And this quarter, we've attended the Medical and Surgical Outcome Review Programme and the Child Health Clinical Outcome Review Programme. And we've also been invited to a couple of new SDMs around 2 national audits as well, perioperative care and MSK. And we've popped a post on the Futures platform for feedback on your views on those 2 new audits, so we can feed those into those meetings. So continues to be busy, and June will be busy with Audit Awareness Week as well. So if we move to the next slide then, and we'll just have a quick look at our improvement priorities. Lovely. So these are obviously our current ones. We share them with you every time that we meet. Kerry and Sarah, our co-op members, are busy progressing their priorities on innovation and measuring success in our local programmes. Marina and I have had a massive focus obviously on Clinical Audit Awareness Week 24 and also the Clinical Audit for Improvement priority, with that particular focus on looking at our network and sharing platforms. And we'll spend a little bit more time with you this morning updating you on that and some changes that are currently underway. So if we move to the next slide. wanted to touch on the NHS Futures platform. So this is the Knowledge and Sharing Hub. Just a gentle reminder, just if you can pop yourselves on mute, please, so we don't get any echoes. Thank you. So nearly 3 years ago now, the Executive Quality Group Clinical Audit Subgroup developed an implementation group that looked at developing the Knowledge and Learning Hub to support taking action on national clinical audit. And as a result of that work, the workspace on Future NHS was created, and it was informed by the user research that was undertaken by a third party for the transformation team at NHS England. And I know a lot of our members were involved on giving feedback into that user research. So you can see detailed here on the slide the shared purpose really of that space around providing that collaborative platform for those delivering the NHS activity to learn and share their experiences of participating in the national clinical audits, and then the impact of actually taking improvement action as a result. So if we just have a quick look at the next slide. The vision was really around establishing that community of practice. So within one platform, it signposts all of those who are working in health and care delivering that NHS activity to know where to go to access your national clinical audit data, your recommendations, your resources and your events. It's not meant to duplicate what's already available on national clinical audit provider portals and websites, but to signpost to those platforms, but to add that element of networking, collaboration, discussion and sharing, so that we're actually supporting one another in that community of practice. So if we just move on to that next slide. The Knowledge and Learning Hub went live on the 10th of May 23, and to date we've got 374 members that are registered on this workspace. So you can see the number of members here who visited the workspace each month over the last year, and we'd got high numbers in May 23 shortly after we launched, and then obviously you can see this slowing down as we've moved through 23 and 24. But if we move to the next slide and look at that in a little bit more detail, 43 of those 374 members visited the site in May 24, so probably about 11% of our registered members, with a total of 88 visits by those 43 members. Now, Carl and I have done a little bit of support behind the workspace with NHS England. So some of those visits were Carl and I think I clocked about 18 there when I looked at our activity. So if you took Carl and I out of that, that's what, 70 visits, 41 members, 1.7 visits per member who logged in. Looking at May 23, then we had 185 visits. That increased in June 23 and July 23. It was 231 in June, 148 in July. So 180 visits in May 23 when we launched versus 88 in May this year. So it has reduced considerably, less visits around the same time this year compared to last year already. So I suppose it's just another chance to raise that awareness to you all today, really, to say that obviously let's see what we can now do to try and increase the visits to the workspace, and then obviously the posting, the threading and that networking. If we just move to the next slide, I think we just had a quick look at some of the hits to the views on folders on the platform as well. So you can see that people are viewing and they're having a good route around the workspace in general. When the platform was set up, the transformation team at NHS England spoke to us, and they did say this is now our platform in terms of this is for our community. It's only ever going to be as good as we choose to make it. And the purpose, as you'll remember, for all of us working in delivering the NHS activity, is to network, share and learn together on how best to take that improvement action on our national clinical audit outcomes. So there's been some really good discussions now started on a number of the national clinical audits, but we need to see that growing, and we need to continue to support one another more. It's a protected workspace where if you're in that provider organisation, you can discuss directly with other peers and also directly with the national clinical audit providers. So it's hopefully going to maximise the impact of us effectively participating in our national clinical audits, and then ultimately we're improving patient care and outcomes. So we need to start now building that content for ourselves. So if we just move to the next slide, please. Lovely. So for anyone not yet a member of the Futures NHS Workspace, I'll just ask some of our NQICAN core members to pop the link into the chat so that you can head on over and just request to join. I suppose quickly touching here again, we've shared this slide previously, and it's about what's the difference between our local forum and obviously the Futures web space. So I suppose the forum's about that collaborative learning and sharing on how we're utilising a lot of that local clinical audit for improvement, and that Futures site is really that focus on those national clinical audits, including the national clinical audit providers collaborating with those of us that are participating in the audits. And it is an important stage, taking action on national clinical audit outcomes to improve patient care and services. So we do need to have that collaboration. So we had some good discussions back in March as the core members of NQICAN, and we made that a decision to move the NQICAN Network and Sharing Forum across to the Future NHS platform as well. So we've taken this decision for a number of reasons. Just briefly touching on these, the NNSF, as you know, is currently on an unsecure space, and we've been looking to try to make that secure. A number of our members in organisations around the country can't access it while it's on that unsecure platform. The support for the NNSF on its current platform is quite labour intensive for the NQICAN team. The Futures platform supported, safe to access, it takes less resource for us to run, and it's one sign-in for our members to access a number of platforms. So I'm going to move to the next slide, and Carl's supporting us to move the NNSF across to the Futures platform, and you've got a few slides to share with us, Carl, haven't you, really, on some stats and just to update us on how we're going to make sure that we safely move all of that resource across and try to make sure that we don't lose any of the content or any of the resources that we've already shared. So I'll hand over to you, Carl, now to cover your slides, and then I'll take back over once you've completed that.
Thanks, Vicky. And yes, so my name's Carl Walker. I'm the UHL, University Hospitals of Leicester Clinical Audit Manager, and I've been previously a former chair of NQICAN, and during that tenure we set up the networking and sharing forum. So when I heard that there was changes, I volunteered to help Marina and Vicky and NQICAN to support this piece of work. So the first thing to update colleagues on looking at the names attending, I can see that one or two joined us for our meeting that we had on the 24th of May, where we sort of scoped this out really with an invite to all members on the forum. And it was great that we had around 50 colleagues attended, and Vicky chaired the meeting. And it was two-edged. It was sort of a reflection of the forum, and to give thanks, and it's helped as well over the last 7 years or so. So and we just noted that there was a lot of posts, and the activity had dropped off of late, and we looked at the root causes behind that, and Vicky's already covered some of those in terms of it being on a separate platform, not always a secure platform, so some colleagues didn't have access to it, and the competitions on people's time, and not having a routine of going onto the forum. So I think basically from consultation that we've done in the meeting and outside, there is still a sort of a need for us to have a forum, and for a forum for our own network of professionals. And certainly we did a little poll in the meeting, and the majority felt that moving the NSF to Futures would make them more likely to use the forums, which was great. So if we could just go on to the next slide, please, Marina. Thank you. And also, as I say, just for transparency, this is what the feedback we got from an anonymous poll during the meeting, where people could feel free to feedback what was good about the forum and what the most important features of the new platform should look like, really. So we know we've got a lot of time, so they'll be shared with the minutes afterwards. But ultimately, we've summarised this feedback into the next slide in terms of a migration plan that we've put together. So if we could have the next slide, please, Marina. Thank you. Yeah, so I think this is a proposal. I know we're going to discuss it at the business meeting later on as well, but this is what we have put together since that meeting a couple of weeks ago now. So NQICAN already have its own futures page that's separate to the National Clinical Audit section of the futures platform that Vicky's just covered. So we think it's probably easier in terms of governance to use the NQICAN existing platform. And Marina and I have looked into that, and we can change it so that we can have bespoke access to that portal. And essentially what we're recommending is that we have 4 tiers of access. So the first tier will be open section, so it's basically anybody who's interested in joining that section of the forum can join, and it'll be a public sharing, so anything that can be shared in the public domain we'll encourage to be on there. And we can share events, minutes from the open forum, etc. So, and then there'll be other sections, which is mainly the peer section, which is peer-to-peer providers of NHS care, sort of workers. And that will be things also talking about regional network meetings and minutes and things like that. And then we'll have the NQICAN business section for regional network chairs and co-opted members. And then finally, there's a NQICAN officers section, so that just the sort of documents that are only accessible to the officers will have access to, but also that'll help in terms of when we have change in officers, there's continuity in where we save all the documents for archive purposes. So that's that proposal. So I don't know, I'll just go through the whole migration proposal, and then we can have a look at comments and see if anyone wants to add in this. I think we've got a bit of time to discuss it. So in terms of content and timelines, we said that as the existing forum was familiar and it had been successful, we'll set up a similar sort of folder structure as we've had on the NNSFF. And but the migration from the old forum would be limited, but we would leave that open as for an indefinite period as a read-only unsupported reference resource, really. And again, that would make it easier in terms of not cluttering up the new system, but also at least allowing people to still be able to pull on a lot of those nearly 6,000 posts that we've got within the old forum. But we'll have a sort of pop-up when you go onto the page to say this is now not managed by NQICAN, and whether we'll lock down so you can't post on it, or it'll be read-only. That's what we've looking into. And then all existing members of the current forum will be invited to join the new futures forum with access dependent on where they fit into the 4 tiers. And we're hoping to go live with this during Clinical Audit Awareness Week, because we think we can turn it around quite quickly, and it's a good week to sort of help with raising awareness of what we're doing within NQICAN and getting encouraging colleagues to network. One of the feedbacks from the user meeting was actually those people that have used futures, there's quite a lot of email notifications that you get from the system, and if you don't manage them, it can be quite a sort of a disruptor potentially if you have lots of posts going onto a forum that you're interested in. So we'll provide some guidance about how you can set up your notifications so you can set it the right level for you. And also one of the good ideas, which I think we'll probably take forward from an NQI perspective, is that we have a schedule of discussion topics that are linked to the forward plan and also these open meetings, that wherever things that are arisen, we can then ask for people to share and comment on things. And basically the aim of the new forum would be to take it to the next level to help the common purpose of NQICAN, and also with the sort of leave no post unanswered type of approach and ethos. And we've advertised for more volunteers like myself to help, and we've had one come forward, which is great. So anybody who is interested in helping with this migration and on an ongoing basis, then please let Marina or Vicky know, or myself, and we'll see what we can do. Okay, so that's I think that was all I wanted to cover. Thank you, Vicky.
Lovely, thanks, Carl. So I think it's yeah, we'll move on with the next slides, and then obviously we've got opportunity for 5 minutes of questions once we've finished the officers update, if that's okay. So moving on then, literally just include this slide again just to highlight to you the events that are being put on by NHS Impact, free to access, that you need to register on. So head on over to either their workspace that's on NHS Futures, or obviously the NHS England web pages for NHS Impact, and you can access some of those events so that you can take forward a clinical audit for improvement within that one continuous improvement approach that your organisation will be taking forward as part of NHS Impact. And then if we move to the next slide, just flagging up as always, more signposts into this fab QI evidence that we see shared with us as a great resource. We can pop the link into the chat again, but obviously if you just Google for the QI evidence, their fantastic newsletter comes up each time, and they've laid it out into categories now that you can see in terms of quality improvement, patients and people, integrated care, and population health and prevention, which is brilliant. So that is always a fantastic resource that's worth signing up for, I think, so that you can receive those straight to your inbox. So if we move on to the next slide, then just really wanted to touch on our regional networks again with you. We're currently made up, NQICAN, of 10 regional networks. We've got the newly merged North West Clinical Audit Network, where we saw Cumbria and Lancashire network merge with Mersey. Still looking for a chair for Greater Manchester Clinical Audit Network. So if you are a network member and feel that you could take on that role, get in touch. If you're not yet a member and fit into the regional area for Greater Manchester and you'd like to join, then please do get in touch, and you might feel that you could take on a leadership role such as the regional chair. We're going to go out for final expressions of interest for Greater Manchester, following which, if we are unsuccessful, we need to start working with the neighbouring regional networks to take forward a potential further merger, just to allow the networks to run for its members and meet the shared purpose and forward plan for NQICAN. So looking at some of our other regional networks around the country, we've got our dedicated regional network chairs running these meetings. They'd love to see you all in attendance. So if you're not yet a member, get in contact to join. And if you are, please do try to get along to support your peers at each meeting. And if you can't attend, consider maybe sending that deputy. The real value of collaboration is when we do actually have these touch points with one another and we are actually sharing and learning together. And the voice of each of those regional networks is fed into the NQICAN through the core members at the business meeting, where we take forward all the ideas, the solutions, the challenges to improve our work streams that ultimately impact on our patients to support them to live healthier for longer. So if we move on to that next slide then, Marina, I think it's over to yourself to give us an update on the General Secretary and Deputy Chair role.
Yeah, just a brief update from me this time. So in terms of reimbursements, NQICAN is in a position to be able to claim some reimbursements through NHS England. So the reimbursements claimed for 23-24 amounted to just under 22,000. We have an allocation of 29,540 for the 24-25 financial year. As Vicky's already mentioned, obviously Vicky and I have been quite busy in terms of supporting the Clinical Audit Awareness Week plans. So please do get involved in those. You know, there are activities running during the week, including our brilliant lunch and learn sessions. So yeah, and obviously another plug, as Vicky said, please do support your regional networks. You know, they're of such great benefit, and we really do want as many hands as possible, and many hands make light work and all that. So please do get involved in supporting your regional networks. You know, I'm sure even if you've got a chairing post in your regional network, we'll be very grateful for any help that you can provide in terms of being part of a steering group, deputy chair, or even just some help with administration support. It is all appreciated. I know that for them. I've been working on the Q4 direct declarations of interest, and as usual, those will be presented in the business meeting later on this afternoon. And the training directory work, which is part of our forward plan, is still there. It's been on hold, unfortunately, due to capacity, but we will get an update on that for you as soon as possible. And that's it from me this time.
Brilliant, thanks Marina. So I think if we move it, yeah, fantastic. Clinical Audit Awareness Week 24 then. So if you haven't heard yet, we're running it from 24th of June to 28th of June collaboratively with HQIP, and there's a national programme of events and resources that you can access in the week itself. So if we move to the next slide, we can see then that just wait for you to lovely move on. Yeah, the launch event was held back in March when we all heard from Chris Gush, who's the new CEO of HQIP, and Danny Keenan, the medical director at HQIP. They both explained the importance of clinical audit itself on improving patient care and services, but also about the week itself in sharing, learning, networking, and that opportunity to shine that light on clinical audit for improvement. 5 themes again this year, resources available, lots of resources on the HQIP website, which I'm sure they're going to touch on within their update today. So hopefully you've now started to put your local events together in terms of your planning for the week, as we're now on 3 weeks to go. So if we move to the next slide, you can see that we've got our daily lunch and learns. Lovely, thank you. So we're running the daily lunch and learns again through the week based on the themes of the day. We've got key speakers now lined up. We've got Monday for patient safety. We've got Rachel Paul, who's the head of safety implementation at NHS England. We've got Kim Ressel for Tuesday for patient and public engagement. Kim's the head of patient and public engagement at HQIP. Health inequalities on Wednesday. We've got Dr. Charlotte Richardson, who's the clinical fellow at the National Healthcare Inequalities Improvement Programme, and we've got Danny Keenan as well, our medical director at HQIP. We've got the Making Data Count team joining us again on Thursday for influencing change, and we're just securing a final and name to be announced for the sustainability for Friday. All events open access on MS Teams. Links are on the NQICAN and the HQIP web pages, so please do join us if you can. Make sure you've got those dates and times in your diary. So if we just move to the next slide, then we can see obviously the page that we put together at the end of Clinical Audit Awareness Week last year, and it was an absolutely fantastic week. So we're obviously planning to make it even better this year for really having that positive impact on improving patient care and services. We'd love to hear from you about your local plans on social media X. If you don't yet follow us, we're at NQICAN. It would also be great if teams can start to share their local resources on our sharing platforms so that we can all share and learn together. Pinch with Pride enables us to have that far wider spread of impact if something your team's developed could actually be utilised in another health and care organisation. Helps to support our themes of influencing change and sustainability around efficiency and resources. So if we just move to the next slide, I think it's just highlighting next quarterly meeting as the 24th of September, and also that we'll be looking to run some local webinars following on from the 5 topics from Clinical Audit Awareness Week, so we can see how we're actually progressing those themes back in our own organisations. And as promised back in March, we're looking to run a local event around how effectively we're actually utilising our healthcare data that's on the back of Jill Stoddard's article that was in the HQIP Cornerstone magazine for 2024. So I think if we move to the next slide, it's an opportunity for questions, I think, to Marina and I, or if anybody's got anything they want to raise around the network and sharing forum. So if we got, I know the chat's been going, hasn't it? So I've been trying to keep an eye on the chat as well, but I don't know. I think we've got Joe. You've got your hand up.
Brilliant, thanks for that. And it's just really in regard to the networks that might be without a chair, just because, you know, there's support from across the other members to really help that, but it's really needed. I know that the East of England NQICAN has been without a chair for quite a while now. The interest from the group is always really big when we have a members meeting, but we again recently went out for expressions of interest and I've not had anything back. I don't know if you guys had anything centrally back. No, gosh, it's about 3 or 4 times we've gone out. I don't know what else to try. As a network, it's a little bit unusual because it has a steering group. So we've been able to maintain the structure of that. And with your support, we were able to sort of reinvigorate it. And that's really exciting. We've got some very passionate people there, but still lacking a chair.
I know, but your model is working really well, Joe, for East of England, because you have got a really engaged steering group, like you say. You've got representation at the NQICAN meetings of one person that then takes that back. So actually you have come up with a sustainable model between you all where you're sharing it. And I know we've got similar model in East Midlands and a few others looking at that as well. So it's, but yeah, if anybody, wants to take up the mantle.
We're really nice. If you pardon the pun.
Oh, thanks, Joe, for that. Have we got any other questions? We're seeing any other hands at all? Okay, so in that case, then I might ask our HQIP colleagues to start their slides, if that's okay.
That's great, thank you, Vicky. Lovely, thanks both. Yep, just to say good morning to everyone. My name's Helen, and I am a project manager at the Healthcare Quality Improvement Partnership. I'm going to begin our update as usual this morning. And just by way of introduction, with me we have Caroline, who's one of our associate directors, and Kim, our head of patient and care engagement. So a little bit about HQIP for those who aren't familiar with us. We are an independent organisation. Sorry, next slide, Marina. And we work in partnership with patients and healthcare professionals and aim to influence and improve healthcare practice and services. So on to my next slide. As usual, I'm going to start with a brief update on the quality accounts list, the directory, and on NCAPOP subscriptions activity. So for the NHS England quality accounts list, as you will all know, the 24-25 list was published in January, but I just wanted to flag that we've recently released an updated version with 2 small amendments, and those amendments are annotated in the footnotes in the document itself. And just to flag that further information, the list for 24-25 and the previous year and any other updates, as always, can be found on the HQIP Quality Accounts webpage. Just also, I think it's probably worthwhile noting that we had a lot of feedback at the last meeting about issues around burden and capacity associated with participating in those programmes on the quality accounts list. And I suppose we just wanted to say that we've noted and shared that feedback with NHS England. And I understand that NQICAN will continue to contribute to this feedback through meetings with NHS England and as part of any specification development and recommissioning processes, I suppose. So on to my next slide, please. So the directory, we now have an updated version, including details on the 24-25 data sets, submission and reporting plans. We also have some new fields, including a topic field and a field sort of covering geographical coverage as well, and there's a few other changes too. Just as usual, to flag that the directory includes NQICAN projects listed on the quality accounts list, but also there are other projects run by other organisations also listed on the directory. So it's certainly not a list of mandatory projects, and it's worthwhile flagging that the directory indicates which projects are included in the quality accounts list for the year. So moving on to my final slide, which is around NQPOP subscription funding. Just a really quick update to say that we contacted trusts in April this year to request purchase orders for the 24-25 funding. And a little bit of good news is that we've now received 100% of payments for our 23-24 subscription fee funding. So I think that's probably the end of my update. Thank you all very much for listening, and I'll pass you on now to Caroline.
Hi everyone, good morning. I'm Caroline Rogers and I'm one of the Associate Directors at HQIP, and I will take us through some recent work that we've been doing. Could I have the next slide, please? Thank you so much. So to start with, our core business on procurement and our tender work on projects, either recommissioning or new projects. So live, recently gone live, are recommissioning of the dementia audit and the child health clinical outcome review programme. Both have dates coming up in June as deadlines for people to put forward their submission to run those programmes for the next few years. We've got a few upcoming tenders to go that we'll be going ahead with. And NQICAN have, well, you take several roles in participating in the process, and Vicky can talk more about that, I'm sure, such as contributing to the specification development, coming to the specification development meeting. So the first one was due to go live 1st of July, we're delaying it for a few days due to the pre-election guidance that we need to follow. So medical, surgical, clinical outcome review programme. So we've held our specification development meeting. As I say, we're ready to go as soon as we can when the new government is formed. The second one, perioperative care audit. A new audit, and current schedule is to go live with the tender in September. And MSK musculoskeletal, that's at very early stages. We're just defining the cohorts and what we're doing, and we've set up a specification development meeting, which is in a few weeks' time, which Vicky, either you or one of your colleagues I know will be attending. Excellent, thank you. And then then we'll sort out the timeline. Well, NHS England will let us know the timeline following that. Thank you. Next slide, please. So the other end, contracts that have been already awarded recently, the Mental Health Clinical Outcome Review Programme was awarded to University of Manchester, and the National Audit of Eating Disorders, brand new audit, awarded to the Royal College of Psychiatrists. And they will be starting shortly. Next slide, please. Well, I ought to say on procurement before I finish that all the tenders are published on the HQIP website. So if we go on to reports, so a few reports were published in May and June since our last meeting. Quite a lot of data releases have been published, particularly from the new cancer centre, so the 10 new cancer audit, well, they're not all new, but the 10 cancer audits that sit in the centre, and a number of State of the Nation reports that you can, the links are there, and you can see that they're the National Diabetes Foot Care Audit and the Paediatric Diabetes Audit, the annual State of the Nation report for their core audit there were published. As usual, all publications are on the second Thursday of every month, always, except due to elections, which is where we are right now. So the June publications and data releases in general, I'll come back to that point, will be paused in June, and we'll get them out as soon as we can once the election is done. And that's just following the standard guidelines for reporting at this period. We are able to release some regular statistical releases in line with other bodies that released planned pre-announced statistical releases can be released as normal, and those will go live in June, but otherwise we need to wait. We always have the publishing schedule, and it's recently been updated to take account of the election. It's on the HQIC website, and it's called the 9-month publication schedule. So you can see for the next 9 months the dates of all the data releases, all the reports, and when they should be released. Thank you. Could I have the next slide, please? So just a little bit on what we've other reports and publications that we have released recently. So the In Focus Impact Report, well, there are 2 impact reports. I want to show you, if I may, because I think they look quite nice, and to try to tempt you to have a look at them. So this celebrates all the work that's been done in the last year across the programme, all the work that you contribute to, all the outcomes, all the great content that's generated, and the impacts that the projects have. And if I can, I will. So we do one, if my screen is sharing properly, we do one that's perhaps the more traditional impact report, which goes into 4 levels: national, system, local and public, and key points from across the programme from each product with the name of the project listed. So you can have a little look at that. And then we have quite a newer type of impact report where each project, this occurs throughout the year, so they rotate annually, so not all projects are published every few months. So this is the latest one, and projects are invited to use their imagination and try to show us in the most creative way they can the impacts that they've had from their projects. So this is the most recent report, and as you can see, they've got some nice, interesting looking impact reports across different projects. So no time to read it now, but please do go and have a look. I'll put the links in the chat, and that celebrates all of the work that you and we and the projects are doing. So if I could possibly go back to the slides, please. Sorry, I realise I probably kicked out the sharing. I'll keep talking, and a reminder, you've probably seen it before. It might have been published by the time we had our last meeting, but the Cornerstone Quality Improvement publication that HQIC releases a reminder that that's out there and is available for everybody to read. And we also just wanted to draw your attention to a blog written by Claire Fountain, our quality improvement lead, on the International Forum on Quality and Safety in Healthcare. And all of these things are available on our website, and I will put all the links in the chat in a minute so that you've got everything to hand. Also, I should say, if we haven't said already, we accompany this presentation with a written PDF update with all the links to everything we've said and everything we're talking about and everything we're doing. So you'll get the PDF with everything after this meeting. And my final slide, please. Last but not least, again, Clinical Audit Awareness Week. Won't talk too much because Vicky already has, but just to say that thank you for everybody who put forward submissions for the Clinical Audit Awareness Week Heroes. Lots of wonderful submissions, and thank you to the judges. NQICAN were on every panel, or a member of NQICAN was on every panel. That's all done and ready, and the winners will be announced at the series of online lunch and learn events, with the winners announced, and hopefully we'll hear from all the winners during Clinical Audit Awareness Week. So that's to look forward to. And I think that's me, and I'm handing over to Kim.
Thanks, Caroline. Yes, next slide, please, Marina. Yes, just an update from Susan. So at the last meeting, Susan Gillespie came and gave an extended presentation about NQAN, the National Clinical Audit Benchmarking Tool, on our website, and the outlier guidance. She's aware that there are some outstanding questions which she is working on, and they will go back to you, Marina, who I think you then put on the forum or the Futures platform. So that will be ready soon. Since then, she has updated new data from the National Hip Fracture Database. And always will welcome feedback on that one. So next slide, please. Thanks. Okay. Oh, back to patient and carer engagement, which is what I lead on. Current projects. The last time I updated you that we had received some small bit of funding from HD Health Data Research UK we ran a 3-month project in which we worked with 3 Sun members as part of the project team to develop resources and tools and a methodology to recruit public members, and we're going to recruit from our service user network to join our data access request group. And that was, I'm pleased to say that that was approved and agreed by our senior executive leadership team. So we have started the recruitment process. And as of Monday, I've sent an advert out to our service user network, which now has about 100 members. And we hope that we will be able to onboard 3 members onto the group by September. So we'll keep you updated on that one. We had a Sun member on each of the judging panels for the Audit Hero Awards, which I think went well. And I was really pleased with the PPI category. We had some great submissions. And then also we've heard a bit about the new upcoming audits that we're working on. So we have specification development meetings next week. And in preparation for those, I've held focus groups for each of those topics, in which we spoke to people with lived experience in both perioperative care and MSK care. So that's everything. And as usual, any patient and public involvement questions, or if you need any resources, please access our website or contact me. And I think that's everything, Marina. I think just thank you, and any questions?
Right. Okay, we've got some in the chat. I was just trying to frantically make sure we don't lose any as we're going through. So there was a question about when will those who've been shortlisted be notified?
They are already being notified. I think they're all being contacted, if not last week, some maybe this week.
Mm-hmm.
So that's the winners.
Yeah.
Basically, yeah.
Okay. There was another question regarding the a potential increase in subs. Are the subs likely to increase given the numbers of projects on the national programme increasing?
We haven't had any indication that that's the case. We haven't started thinking about the funding for 25-26 yet, so I've got nothing further, I suppose, to add to that.
Okay. And then another one in the chat, NCAB still publish old data which does not reflect if a trust receive an alert on, for example, increased mortality. This needs to be looked and updated.
Yeah, I think Susan had this question last time and was looking into that. Caroline, do you have something to add?
Yeah, well, I was only going to say we are well aware that NCAB is not as up to date as it could be, and it's outside of HQIP's control, I'm afraid. What can I say? It's something we know and we work on. NCAB fulfills one function. If you've got something more recent from the project itself, then obviously the more recent from the project itself is what you need to look at.
And then another one asking, can the number of entries across each category for the awards be shared and compared to last year? So it'd be good to know the numbers of entries.
Yeah, just saw that from Stephen. Hi, Steve. Yeah, I think comms, our Lacey Ashman will be putting together some slides and comparison data after the event.
Yeah, we should be careful not to measure success. It has gone up this year, I heard somewhere, but at one point in the past, I can't remember if it was last year or previous, we changed the criteria because actually we felt that we had a lot of submissions which, while great, were perhaps not as focused on clinical audit or quality improvement as they might be, let's put it like that. And we certainly don't want to waste anyone's time putting in submissions that aren't relevant to topic, and we just can't judge because they're not on topic. So we tightened up the criteria quite a lot. So if we have, so as I say, I think they have got up, but I wouldn't measure sort of success as just number of submissions. What we like to see this year is that there were lots of really high quality submissions and that on topic and meeting the criteria, and we're able to judge really well and find, easily find winners. So so that would be more of a measure of success than me, but that might not be what the question implies, but I would just note note caution about numbers, although, yeah, we're really pleased to see lots of submissions.
Yeah. Okay, another one in the chat. I think this year there was a delay in the publishing of national audits, right? Question mark. There's been a delay in the list.
Oh, the
publishing
list of national audits.
Yeah.
Do we mean the directory?
I'm not sure. Is it
Quality
the
accounts list was
what's in
out,
that? I was
wasn't it?
just going to say, was
the
it the quality
directory.
accounts? Yeah.
The
Oh, the
directory, yes.
directory.
So the directory is published, actually this is really Helen's, but I'll just start by saying the directory is published every month or updated every month, but the complete and full review, which
Yes.
Helen did an awful lot of work on this year because quite a lot of things have changed, was, I think, yeah, it was a few weeks later than it has been in previous years. I don't know, Helen, if you've got any more to say about that. We tried our absolute best to get it out when we can, but given a lot of things have changed, Helen worked day and night to get it out fully updated and we're now confident of it, and now it's been published. Did you want to add anything, Helen?
No, just to echo that, and just to say that we get that it would be better if it was at an earlier stage, if the full version was released at an earlier stage in the trust sort of planning cycle. So we'll try to incorporate that into our planning for the next big review.
Thank you.
And then we've got 2 with hands up. Sarah was first, or might even be 3 with hands up. Sarah first.
Thank you, and thank you everyone, and great update. Thank you to all the team. Really one for Caroline, I think, and perhaps for Kim. Thinking about the impact report, Caroline, I just think it's really profound to see impact being looked at properly, particularly within the clinical audit arena. I think it's too easy for folk to be thinking about the clinical audit cycle, but front loading it and all the data collection. So to see impact is really, really good. I just wonder if perhaps I could put a request that we have a future presentation for an open meeting that actually looks at one of the impact reports and looks at the impacts. And I know that you're not the owners of the information necessarily, but looking at actually, we set out to do X, we've done this, the impact is this, and that's Kim's area as well, but looking at experience as well as actually outcomes, because I think that helps support all of our programs and also helps support when we think about CQC inspections. So it's just trying to change the agenda and think differently about impact. So it's just a request, if that's okay.
Yeah, Sarah, that's a fabulous idea. I'd love to do it. Well, I might not be the best person to do it, but you know, we would love to do that, I'm sure, because like you say, the day-to-day is often very important, but thinking about the impact is very, so it's very important to us, and it's very important to our commissioners, and those reports are taken a lot of notice of by NHS England, Welsh Government and everyone else that we pass them on to, but it would be lovely to share some of that, wouldn't it, more widely? So yeah, thank you, brilliant idea. I don't know why I didn't think of it yet. Great,
it would
love
help
to.
Reframe the thinking. It would help us to start looking at, actually, are we looking at the need, and are we really generating a change? Is there really a change in impact? So thank you.
Yeah.
And next question is Carl.
Thank you. Thanks for the update. It's always good to hear that things are progressing, because spent a lot of time on this over the last 10 years or so. But is NQICAN part of HQIP, or is that separate? You know, the national, what's the acronym? I'm going to speak
It's
National Cancer Auditing Collaborative Centre, isn't it?
Yeah, NQICAN doesn't stand quite for all the letters. Is it part of HQIP? So HQIP, now a plug. I'll do the plug in a second. HQIP commission the centre, slightly different model of commissioning. So we commission the centre run the audit. So absolutely part of the NQICAN, absolutely part of, but commissioned by HQIP. We have an hour's session on NQICAN and the outputs and how the data is collected through the routine data and the everything else to do with it in Clinical Audit Awareness Week, and I believe it's the Thursday afternoon, 4 o'clock Thursday. I'm going to guess with the 27th. Quickly look in my diary, yeah, if someone could nod. So everything about that from NQICAN itself, an interactive session. So please attend, and you will find out everything about it. And I'm sure we'll record it or share it in other ways if people can't attend. Yes, it's Thursday the 27th of June, 4 p.m.
Yeah,
Great,
and
thank
all
you.
the list, actually, I'll put it here, the list of not just the Learn at Lunch, but all the other webinars
as well
on that page.
because I've done a scoping exercise, because a lot of the well, not a lot, some of the fields that are needed for NatCan aren't collected as standard on Somerset, so there is quite a bit of work for local trusts to sort out. So it's just a heads up to my peers on the call, really, just to say, and also the clinicians I've spoke to haven't seemed to have been aware of that it's coming. So I don't know what comms has been done in terms of the detail, but that's just some feedback, really, just to try and, obviously the event during Clinical Audit Awareness Week will help, but it's just that yeah, it's going to be more extra work for trusts, and there's 7 or 8, isn't there, on there for acute trusts.
There's 10 audits, 4 of them existed previously and 6 are new. That is the ideal session to ask all of those questions. We think we've been shouting about it for ages, but it's very, but obviously it's really hard to reach everybody everywhere. So we need to do more on that from what you've said, understood. And this is, as you say, the event in Clinical Audit Awareness Week is part of that. Plus there are individual specialty events and the specialist societies, and all of these bodies are ramping up now that the work has started. It is sucked from the routine data. So if it's not collected, yes, you know, the idea is it's collected, but it shouldn't. Well, as I say, there's not data entry or any platforms or anything like that. It's all about the data that's collected. But good points to raise, and this is where we start. Yeah.
So in local trusts, some things aren't collected as standard, so you just need to change that so that it is collected, because it comes off the Somerset system. So yeah, it's all integrated.
So, and there are changes, like the 2. If I think of the 2 gastro audits, which used to have their own clinical audit awareness, clinical audit platforms, they've gone. So no entering data into those. The data's coming off the routine data.
Okay. And then we've got one from Zoe, I think, is next.
Good morning, everybody. Not a direct question, just a bit more feedback from staff that I've been given when I've been doing some one-to-ones around some of the national audits. In terms of the national audit at the care of end of life, the staff have reported back that the quality survey has gone from 3 months and been extended to 12 months, which has had quite an impact on them because it's paper-based, so they're having to pick that up. We'll be feeding that back to NACL directly. The return rate is not great because it has to be paper-based, and we're only getting 11% return rate on that. In terms of the nil and no lap element, we're finding it quite difficult to identify cases because we're looking for something that didn't actually happen, in like the surgery. So we're only looking at 2 conditions at the moment, which is looking at increasing next year. But we're doing we're asking registrars to spend a lot of time looking through notes to identify the no-lap cases, and we haven't found any yet. So the conversion of looking through the notes to finding the cases that we can put onto that audit, it's just taken a lot of time up at the moment. So I don't know whether that's something that Nella can look at, but again, we will feed it back to them. We've had some meetings with NatCan. I think we've had a meeting with the breast team and also kidney team. We're still trying to find us way around what's going to come out. The kidney team have told us that report 1 will look at 4 criteria from October 20 to September 23 and not everything. And then report 2 will look at other criteria, but only look at up to June 23, not including up to September 23 like the first report is. So we're trying to find us way through that with NatCan at the moment, but I think we anticipated that we would get everything quarterly and it would run nice and seamlessly, but we're not actually finding that at the moment. Let me have a look and see if there's anything else on there. No, I think that was it. That's the feedback from the staff. And I suppose my question would be for the national clinical audits, when the teams that are providing the audits want to increase their data set or change things like the quality survey from 3 months to 12 months, what process do they go through to make all those changes? Do they have to come to HWIP and say we want to change this, or are they just allowed to do it?
Should I take some of those?
Sure. Marina, would you mind sharing the screen so that we can see? Thank you.
So I'm on dodgy ground speaking about NACL because it's not one I know well, but I will, and one of my colleagues manages the contract, so I can certainly ask him about it. But what I would say, the more general point is the criteria is all set out at the beginning and the way things are going to run. If anything was going to change, it depends what sort of change. Minor changes to make it work better. Yes, of course, we expect projects to act with autonomy. More fundamental changes that affect, that affect lots of people and affect lots of trust, we'd expect them to consult with us, consult with NHS and consult with NQICAN, so changes are made in that way. So it depends on the nature of the change. And I'm afraid I don't know too much about that particular change from 3 months to 12 months. But all of the audits are run by clinicians. So they are in trust. They know they have their own work. That's a requirement that we have for all of them. And they all have project boards that include, many of them including local audit members. And we're always having a call out for NQICAN members and associates who want to join these project boards to join them so they can participate in these discussions to get the design of the audit working for both the funders and the commissioners and the audiences and the governance and the people who participate. So that's what I say on the more general point, but I'll find out more about the specific point. I wanted to say about NOLAP, there was some nice conversation on the forums, wasn't it, for people who know that, about what to fill in and how, and I wondered if that might be a suitable place to sort of share the building up of knowledge for something new like that, and who's a good person to do it and how they've gone about it and how many cases and how to find them, so that that should be a really good place to share and develop together is what I'd say about that.
Yeah,
Did I miss any questions?
No, I think that's great. Thank you, Carol. I think we have the facilitator in question has already put a question on around the NOLAP. And I put something on there on future NHS regarding the impact, how people are finding that, and how they're going to collect that data and how they're going to identify the cases. So there is some questions on there started. So hopefully we'll get some more responses.
And if you don't get answers, well, let me know or post again. What I love about the forum is that the people are able to share knowledge amongst themselves. People are actually participating and know on the ground what's going on. But I've really encouraged each of the projects to be on there so that somebody, if it's a question that the project should answer or could answer, they can answer. And then everyone will see their response rather than one person getting a response to their specific question. Everyone should be able to see their response. So the more we can use that to build up that knowledge.
In all fairness to them, Caroline, they did respond. The project team did respond to say how important it was that we contributed to the NOLAP, which is great, and I don't disagree. It's just the practicalities of finding those cases, really. But yeah, let's see how that one develops.
Okay. And then we've got one more hand up.
Can I just come back on the NACEL, because I did actually attend a recent CRM with NACEL and we talked about the quality survey. And I was just trying to remind myself of the work, because I know that they did go through a big change, and it's not just paper-based, it is online, it is available online as well. And I'm not sure, I think there's a comment on the chat that it's not actually mandatory. So I think it's worth looking at. We'll go back to the Associate Director on that one, but I'm pretty sure you might want to look, there might be some changes in the requirements there.
We will, thank you. That's good, Kim. We'll have a look at that. I think one of the things that we discussed internally was the electronic, having it on a QR code and things like that. But when we're talking about care at the end of life, when you go into next of kin and things like that, you might get people that are actually quite elderly that you're sending that to as well. And possibly they don't want to use a QR code, or maybe don't know how to.
Yeah, that's fair enough. Thanks.
Okay, I'm conscious we've still got 3 hands up, but we're on 11:05 at the moment. I was just going to ask the 3 people that have got your hands up if we're okay to move on, but we have got a little bit of time for Q&As at the end as well.
And Vicky, there's a couple of questions in the chat that we probably haven't done justice to yet, so I'll try and either type answers or maybe we could come back to it at the end. Or
lovely, brilliant, thank you, because I'm aware we've got Stuart Monk. Stuart, you're on the call, aren't you? And you've obviously joined us from the Health Innovation Network to give us an update on the medtech funding mandate. So hopefully you'll be able to take yourself off mute, Marina, or screen share again and pop the slides up.
Great, thanks, Vicky. Can you hear me all right?
We can, yes.
Great, thank you. Good morning, everybody. First of all, it's great to be here talking to you all. And I think over the last last year and a half, I think, since I was speaking to you previously at one of these sessions. We've seen some really good links built between our network team and your members, so that's really good to continue to see evolving. Purpose for me being here to talk to you briefly today is to just summarize a lot of complexity that's happening around medical technologies and strategies, policies that some you might have seen. One went live a week and a half ago. So I just want to try and summarize some of what's happening around sort of national med tech strategy and initiative as best I can in a way that might help you in some of your local work. Next slide, please. Before I get to the actual medtech bit, I'm going to talk through, and for those of you that aren't familiar with the Health Innovation Network, in brief, who we are. Describe ourselves as a network of networks committed to transforming lives through innovation. Talk about where we get our funding from shortly. You can see the 15 in England. So there are 15 health innovation networks covering the 42 integrated care systems and also working with the 7 NHS England regions. On the next slide, please, if we could go to that, you will see where we get our what we call our core commissions, our core sets of funding from. So NHS England, the Innovation Research and Life Sciences team in NHS England is our main commissioner. And also commissions us to deliver the Patient Safety Collaborative. So that's the block on the left, and the block in the middle is the work that we do around supporting the development and spread and adoption of innovation. So that's where we get most of our funding from. We've also got a commission with the Office for Life Sciences, who mainly commission us to support SMEs and innovators to develop their innovations in a way that hopefully will resonate one day with an NHS need and may even be procured into the NHS. So yeah, patient safety on the left, developing our own pipeline and supporting spread and adoption in the middle, and supporting innovators over on the right. That's our sort of 3 core areas of activity. On the next slide, please, you'll just get a quick some quick insight into how we work with our sort of commissioners and governance. So I mentioned the 3 national commissioners that we have. Locally, we are then quarterly assured by the 7 NHS England regional teams. So yeah, different health innovation networks are covered by different regions, obviously. And ultimately, what all of that enables us to do is to work both as a network nationally. So we do a lot to yeah, spread things together, transfer learning from one region to another region, take in implementation learning from different ICSs into other ICSs. But then locally, we're also able to adapt to local needs and make sure that the work that we do as part of the local side of our commission resonates with what the ICSs in each of the region and in each of the Health Innovation Network regions is actually doing. Next slide, please. Just in brief, our aims through all of this work, we do try and foster a culture of innovation. We want new ideas to thrive, innovations to spread faster so that patients can benefit. We're now starting to talk more and more about these sort of 3 core aims, which are probably covered in the commissions, but just to draw those out a bit more. Discovering and developing promising new innovations, matching and developing innovations to meet unmet need in the system, and also deploying innovations at scale to improve patient care, improve workforce life as well. And the final slide from this bit just talks about our impact. If you could move to that, please. These are some of the sort of cumulative impacts that we've had since we've been around for the last 10 years. The thing I haven't mentioned actually that I should have done is that up until October last year, we were called the Academic Health Science Network. So some of you might have been familiar with us in our old guise. We're now the Health Innovation Network. So yeah, millions of patients have benefited. We're supporting about 1,500 innovations at the moment. Through the work that we do with industry, we think we've contributed just over £1 billion in economic growth. In total, lots of companies have been supported. We think that for every £1 invested in us, we're returning an investment of about £2, just shy of 3. And we've safeguarded quite a few jobs as well along the way. So quite a breadth to the work and the impact that we try to create for different people working in health and care innovation. So if we get onto the next slide, this is the main crux of why I'm here. I said I would talk to you about medtech strategy and policy initiatives. There's loads going on around this at the moment, which I will try to summarise. Going back just over a year, Department of Health and Social Care published a medtech strategy that I'm sure some of you have read. Very long document. It was published and led by the DHSC's new medtech team. So they're led by a chap called David Lawson, who used to work in procurement actually at Guy's and St Thomas's. So that's great. David's got real world experience to bring to his role here. And this strategy set out lots of different initiatives, basically from the pandemic learning, really, to try and tease out a much clearer route for medtech prioritisation in the NHS England world, and how procurement processes and such like can be made a bit more streamlined. So the strategy's got a lot in it. I mention it here because it's catalysed a few of the things that I'm about to talk to you about that might be impacting a bit more on your worlds in the NQICAN network and in your providers and trusts. So if you could move to the next slide, please. Something that launched a week and a half ago that some of you might have seen is what's being called the rules-based pathway for medtech. There's a visualization of the pathway on this slide. And when the slides are shared, if you click on that link in the title, it will take you off to the consultation page as well. So this consultation has just gone live. So NHS England and DHSC have developed this pathway. What the pathway essentially does is it sets out what I would say, reading between the lines, a commitment really from NHS England and NICE especially to be working together a bit more systematically to support the scaled adoption of medical technologies that deliver biggest clinical benefit, cost effectiveness benefit, and hopefully workforce benefit too. So really interesting to see mapped out. I guess main message for you all here is to, work with your colleagues to go and have a look at the consultation, which you can access via this slide. I'll pop it into the chat as well. Have a look, have a read, think about the practical side of it from your perspectives. Think about what impact this might have on trusts and where you see some of the issues potentially arising with it. But I just wanted to flag it here because it's an important opportunity to input into this process. Nice colleagues that are following me might be talking about this in a bit more detail as well. So that's the rules-based pathway. If you can move to the next slide, something that you are all familiar with is the medtech funding mandate. Now, there's another thing happening at the moment called the Innovation Ecosystem Programme, and there's no sort of big broad comms around this at the moment, to be honest. It's been happening since probably back end of the summer last year. It's led by Roland Sinker. There's a picture of Roland there, who was commissioned by Amanda Pritchard actually to look at the research and innovation landscape or ecosystem. Obviously, we're a big part of that in the Health Innovation Network. To just see how it's working, to support the spread and adoption of innovation, how it could be improved, and to make some recommendations basically. In terms of how it's actually doing that, I would say there are 3 key areas of work that this programme is looking at, and we're involved in some of these. So there's something around horizon scanning for future trends, things like genomic medicine, artificial intelligence, robotic process automation. What are the things that are either here or that are imminent that the NHS should be preparing for? So there's some work there. The second area is actually looking at current policies and programmes. So that's looking at us in the Health Innovation Network. It's also looking at the medtech funding mandate policy. I know that many of you will be familiar with, to just see how those mechanisms or policies or programmes are working, and again, what immediate actions can be taken to try to make those better than they are already. And then also a broader point around harnessing learning about what's happened in the past to support the spread and adoption of innovation, what got in the way, what worked well, and how do we make some of those key learning points even more explicit and built into national policy documents, and then hopefully regional and local delivery. So that's the Innovation Ecosystem Programme, and I'll talk a bit more at the end about when all of these different things are due to reach their next key milestones. So yeah, on here I've mentioned the medtech funding mandate. So if you move to the next slide, please, it's a little bit more information about the what next for all of these areas of work. So yeah, the medtech funding mandate is being reviewed under the Innovation Ecosystem Programme, and that's happening, you know, as part of the work more broadly that's happening around that rules-based pathway, because there's obviously a lot of crossover between those two things. In terms of the what next, we're expecting all of these different things to start reaching conclusions at the back end of the summer / autumn. So definitely encourage you all to go to the rules-based pathway, input into that consultation process based on your local experiences and thoughts. And maybe I can come back to one of your meetings in autumn time or beyond, Vicky and team, and once we've got some firmer recommendations and some firmer direction from some of these initiatives, talk through what those things are and what they look like. It was a bit of a whistle-stop tour, to be honest, but it feels like there's a lot happening, although there's not much that's been finalised yet. But hopefully that's useful just to bring you up to speed.
Yeah, no, that's brilliant. Thanks, Stuart. You know, that consultation, how long is it running for? Just so people know how long they've got.
Yeah, that's a good point. It runs until the 15th of August, so quite a long time, actually. As a network, we're going to be working as like a single entity to input into it. And I would say that probably having sort of seen these processes play out before, the more that you as like a single organisation or system can input in, I think it tends to carry more weight than just, you know, 100 individuals from the same big acute hospital all inputting individually. I'd encourage you to think about how you might input as systematically as possible.
Yeah, I think that's key, isn't it, now as we're moving to that more systems approach, and it's worth collaborating with your peer organisations around how you're taking that innovation and adoption of technology forward, so you can have that joined up approach and alongside your ICBs as well. You're all together having that conversation, and we know we're linked in now with our HINs as well, our regional HINs, to support us in that. That was really useful to do it, to have that quick update, and also signposting us to the consultation. We obviously want to know that we're being kept up to date. We're not actually missing anything that's going on strategically wise around these work streams. Has anybody got any questions for Stuart?
Sarah, go for it.
Thank you. I don't know that it's a question. I was just thinking about the next steps in light of the workshops that the workshop we've done to date together. I suppose just while I've got the floor and it's open mic, it's great to see the Synca review. It's really great to see your update. I think where the health innovation networks, where the evidence-based approaches can help us, this community, is again really thinking about the impact. So thinking about implementation and how we get new technology into health and care to benefit our population, so to improve outcomes and to improve experience. So it's great to be able to see that and really to legitimise how we can support one another with regards to implementation, you know, working collaboratively with the health innovation networks. Vicky, did you want to say about the workshop and what we'd proposed with Stuart to do next? Shall I hand the baton to you?
Yeah, I think so. It's because obviously we ran the first workshop last year. I've forgotten the date that we actually ran it, and obviously we set
October,
out initially.
Yeah,
we set out initially to run a series of the 3, and obviously because there's been national changes in the direction of things that we've gone behind it, we've been mindful that obviously anything that we're running with NQICAN and our wider clinical audit community fits with those changes. So obviously we've not yet run workshop 2, and the agreement that I think we all came to when we met was that we would put out a survey to our members post today's update from Stuart, so we can actually gather the thoughts and actually start to design the follow-on workshop now, so that we're actually working together collaboratively to support each other to make sure that we are considering adoption of these wider technologies into health and care. So watch this space, I suppose, for the survey coming out. And the other thought I had as well is that obviously the medtech funding mandate. We've got the workspace, haven't we, on futures for that area of work as well. So it's probably worth heading over if you're not yet a member of that workspace as well, because again, there'll be lots of threads and discussions on there, won't there, from people that are adopting the technologies as part of that within their health and care organisations. And then I suppose quickly going back to our series of webinars and the work stream that you're leading on, Sarah, as co-opted member, is really thinking about, obviously, as we've brought this to the attention of our clinical audit community and wider QI community, it was about actually how it's not just the consideration and adoption, it's the actual measuring that impact of it, and how obviously we were promoting clinical audit as a good QI tool to measure the impact that that's having on our patients and obviously their health outcomes. And going back to the point that we made at the start of the meeting in the officers update around trying to support our patients to live healthier for longer, and addressing that equity and access issue that a lot of our local communities are challenged with.
Thanks.
Carl.
Sorry, Vicky, Sarah, just before we come to Carl, just to build on what you both just said, I think it would be really helpful actually if for all of you in this network, when you're inputting into the rules-based pathway consultation, to think about those two areas, the implementation challenge, Sarah, that you mentioned. Like, I don't think in any of these policies that's ever thought through in terms of the resourcing, in terms of the complexity that implementing a new thing actually, you know, takes. I think that's really important. And, you know, that's one of our key messages from the network. But if that's also coming from, you know, the front line, as it were, then I think that would be really helpful. And then your point, Vicky, on measuring impact, again, like once you've implemented, it might not work for whatever reason, or it might not work in the way that we thought it was going to. So again, you know, being able to encourage systems and give them the time and the breathing space to measure that properly.
No, Tyler.
Sorry, Carl.
Yeah, no, I think Sarah and Vicky have touched on main points I was going to make. And first of all, thank you, Stuart, for that update. It's not something that I'm terribly up to speed on, so it's great to have that overview. And I know through doing my improvement specialist training at the moment, medtech is quite key to having force functioning changes to make improvement really happen and not rely on humans to remember to do the right thing. So I think this work is very, very important. And again, like we said, the rollout is important, but also picking the right sort of device or solution is important to test out through improvement methodologies, because in a local setting, not everything works as you'd expect.
No, completely agree. Well,
Brilliant.
thank you all for having me along. I'll come back again, hopefully at your next meeting, to give you a bit more of a concrete update.
I think that would be brilliant, Stuart, especially as you've said, come autumn, a lot of these programmes are starting to come to their conclusions. It might be quite nice, maybe for the December meeting, then if we schedule on the agenda to come back to, and then obviously our members will hear from us before then with the survey, and obviously any more how we're progressing the webinars as well. So that was, yeah, thank you for joining us. That was fantastic. You're welcome obviously to stay, because there's the Q&A at the end, and obviously we're just about to hear from NICE as well. Thank you. So I'll hand over to Joe and Craig now, if that's okay, and we'll cover the NICE, and then that still allows us time at the end for more Q&A.
That's lovely, Vicky. Thanks ever so much for that. And I am without my co-pilot. So Craig isn't with us as far as I'm aware. So I took his name off the slide and I'm flying solo. My name's Jo McCormack. Lots of you are very familiar with how I work for NICE. I'm a nurse by background, but I have been with their implementation support team for sort of the last sort of 7 years. Craig's in the team with me. There is currently about 6 of us. There were a group of 10, but we're currently a group of 6 based regionally to support that local implementation. We're part of what we've sort of relabeled as impact and partnership, but it is that system implementation support. we do work very closely with a national version that sits within NICE as well. But it's really great to be here. It's really great to hear from the other speakers as well. And what I've got today is just a bit of a strategic update for you in terms of what NICE has been doing and where it's going, because obviously we're all part of this journey as supporting the health and care system in the current environment is probably sort of the right words for that. That's lovely. I haven't got control of the slides, but if you're all right to keep that, Marina, I'll just say next slide if that's all right. That's lovely, brilliant, excellent. I haven't done a slide set which talks really about NICE, but I'm sure you'll all be aware our main purpose has not changed, and that has always been to help practitioners and commissioners get the best care to people fast while ensuring that value for the taxpayer. So we review all the evidence for evidence-based best practice, and I suppose it's our methods and processes that has given NICE such an important role here. We do that on behalf of clinicians so then they know what to follow, and I suppose historically we've done 300 guidelines to date. That's probably about 20,000 recommendations on what the evidence tells us should be best practice across that big range of topics in health, public health and social care. And over the past sort of 2 or 3 years, we've really focused on, you know, how do we need to transform in the post-COVID era with all the changes and pressures of the system. And this was an initial idea, and obviously it's gone a little bit further now. So it's about that relevance of NICE, focusing on what really matters most. We knew we had to be more timely. We knew it had to be easier to use, so you can find what you want much easier. And we wanted to increase our impact. And in order to do that, we felt we needed to be aligned and working in partnership with perhaps the HINs, closely with the perhaps NHS England, to make sure that we were all giving consistent messages and NICE was adding value and definitely not doing things that meant that we weren't making things very easy with that. We were saying things that perhaps weren't in line with other people. So we do happen to commission the BNF. We're responsible for the Cancer Drug Fund, and we produce guidance. And sometimes that's the approval of drugs, isn't it? But largely it's the guidelines that people follow for what's safe, effective and cost-effective practice. So none of that's changed, but we have still maintained that focus. So it's 1, 2, 3 from the middle of that slide. And we've taken a few steps over the past sort of 18 months to really progress that, and that's some of what I'll share today. Next slide, please. So if you don't get all the detail today, you'll obviously have the slide set. There's a lot more information on some of those slides, but what I will touch on is the technology appraisals, the drugs, and moving that into guidance. So we were aware that clinicians would have to go to multiple things in order to see what we said on a topic. They would have to go for the TAs, then they'd have to look at the guideline, then they'd have to look at something else. So what we're doing at the moment is incorporating those TAs into guidance so you can see them in one place. We're going to work towards integration. So slightly different choice of words with that, and I'll talk about that when it comes up in one of the other slides. We've listened to feedback, so we make that baseline assessment template available as a tool and resource. It's a really simple copy and paste of our recommendations into an Excel spreadsheet, and a lot of organisations use that nationally. What's their baseline for what NICE has said for the recommendations? How are they following it? Where's their gaps? Which enables them to make an action plan to address those gaps. And we've done some changes to that. What we knew is when we change a baseline assessment template, it causes a headache for you guys. We might have changed the recommendation number. We might have removed some recommendations. So I've got a screenshot of how different that looks in case people haven't come across that just yet. It's a new work in progress. We've just started to do that. I've said new website. That probably is more to do with the software and what sits behind the website for us. You won't necessarily notice big changes to the actual homepage, although some of you might have noticed slightly different reordering of that, but we have technically a new website. For us, we have a features section where we have collated some of our case studies rather than have that on a separate page of shared learning. Some of you may have come across that before, you know, sharing that story of how somebody's implemented NICE, their challenges and how they overcame it. We're really keen to collect those case studies and support people in perhaps writing those up for them and showcasing them on the website. So it's slightly different feel in terms of where that is on the website, but we are still keen with that. In sort of the last 18 months, we started something called early value assessments, and that's largely with the medtech, isn't it? In terms of, you know, it looks really promising, but perhaps all the evidence isn't there of what would normally satisfy NICE for that big tick. Sometimes the funding hasn't necessarily been agreed. The evidence hasn't been completed, but it is looking promising. And what we've done is we've said we'll do an early value assessment of that. We'll say, you know, what we found, make that available, but please collect more data on that. And we're monitoring that. So it's often been published as HTEs. So a lot of the products that we make have these different sort of initials at the start, NG for NICE guidance, and we have a HTE for early value assessments. And the development of that is what we've not done historically is look at things that are standard practice. The variation in the types of beds that are purchased across an organisation, the type of slide sheets that are used, the type of stent that's inputted into the heart. We often, unless we've been asked by industry to look at something, we haven't normally done that comparison if things have got to the stage where they're very much standard practice. But we know they can be a really expensive cost for organisations. So we have been asked if we'll do late stage assessments on things. So they're things that are generally standard of care. They are things where there could be potentially big cost savings with that, but we're doing that comparison for people in terms of, you know, there's a range of things under that scope and which one would you use when and which one would be best. That's a new thing for NICE. It really is just in the pilot stage, and I might mention that as we go through the slides. I've put new guidance wording. I'm not going to give you any sort of tease of that in advance of the slide, just to say that when we publish different products, we often use different terminology. So sometimes we would say consider or could or should, and we want to be a lot clearer of that, and we want to use the same terminology across any of our products. We want to say you can use this, you shouldn't do that, or don't do that. So I've got that on a slide as well. I've put the paediatric early warning score in there, and I've got some slides which talk about it in detail because it's sort of a very typical query that we could get asked, and I think it's a really good query. So NICE guidance hasn't yet been revised in line with the paediatric early warning score. So when is NICE likely to revise their guidance? When organisations introduce this PEWS, they won't be compliant with NICE guidance. Is there a timeline? I think that was a great question. It's a very typical query that we get. I've sought advice from across NICE and in particular one of our clinical advisors, and I've put that on a few slides near the end. And then I always tend to think what's coming up that may be of interest, and I've just put that on a final slide. So if we don't get to cover things, or there's a lot of questions on some of this, people can refer back to the slides at a later stage. Brilliant. Next slide, please, Marina. So these next couple of slides are just some highlights of our work for 2023-24. And what I would say is if you have engaged with us in this past year or so, thank you. We've done quite a lot of surveys when we try to do any changes because we have to prove that we've consulted on stuff, and we want to listen to the feedback on stuff. It's absolutely no point us producing stuff that people cannot use, that lacks the implementation support, that really isn't a priority. So we really value the opinions that people put forward to us. We don't often close that loop to give that feedback, but we have been very grateful where people have engaged with us in all the changes that we've made over that past couple of years. So perhaps just a couple of highlights with that. On the far left, we do say yes to the majority of technology appraisals, the drugs there. We do have requirements actually to meet that cost effectiveness that European guidelines and guidelines from elsewhere don't necessarily consider. So the remit in terms of that negotiation sits with NHS England, it doesn't sit with NICE, but we have said no on the proviso of cost often if it's just not affordable across the NHS. We have very strict criteria with that. We've got severity scores that are new for us with that, but it was just really to flag that. And then, as Stuart mentioned, there's been quite a lot of increase in terms of health tech. So our health tech guidance is reflecting that now. We never used to publish very much on that at all, but that really has been a big focus for us and will continue to be a big focus. There's probably very few new guidelines coming out from NICE. What you tend to find is there's updates. And what we've tried to do is grab our guidelines into topic suites. So you can now see some of those topics, the topic of mental health, what falls in under that. And we've put in that topic suite, you know, any guidelines, what the stage they're at in terms of we are updating this section on this guideline. We are looking at this, we are looking at that. Perhaps if we're looking to pause or something is going to be, I suppose if we were going to withdraw something or supersede it often, then it's all there together in a topic suite. So we're trying to show that as well in case that's helpful. Much more of an advancement in terms of real world evidence, that real world data, you know, the data that's collected, you know, in the patient population in real settings of how that would come across, and that data being collected. It does give us a whole raft more of data than we've ever been able to use before, and for us to be able to sort of analyse that. Brilliant. Next slide, please. And that's just a second slide in terms of what we've been up to. The idea of increasing access to our website, but making it easier to find what you need, what you want more quickly. It said launched in May, and I've been on this morning. I can just see the reordering, so it's not a big wow change. Obviously funded by the taxpayer, we're quite mindful of that, but we want to make it easier for people to find what they need. I've just mentioned about bringing guidance together in a topic, mentioned a little bit about those late stage assessments that are coming through. And again, that's really to help commissioning in terms of the right product for the right price with that. I mentioned a little bit about real world data. Measuring and illustrating uptake. So that's not something that NICE is really focused on. You know, there's not this compulsory response that when we've made something available to say, you know, how are people using it? You know, we don't see those baseline assessment templates, so we don't necessarily follow that. But we do use the audit data and data sources to think, especially our quality standards, you know, those view statements and the suggested measures that come with that. You know, what's our uptake of NICE? Is there big disparity in areas or between things that we could focus more of our implementation efforts to improve that quality across the board? And we've got a new sort of strategic approach in terms of people and communities there. Lovely. Next slide, please. So I've got the next sort of 3 to 4 slides where I've got quite a lot of detail in terms of what we aim to do for an improvement and sort of transformation within NICE and what our activity reflected on. I'm not going to go into these in any detail, but have just pulled out, you know, the odd thing from one thing sort of from each slide. So optimising how we produce guidance. Many of you have completed surveys for us, and we've improved our methods. And we've been tasked with doing that late stage health tech. Next slide, please. So probably in terms of that focus on what's most relevant and important in terms of those priorities, the big thing on this slide is probably the prioritisation board. So we had various different routes for nice to hear about topics that were coming through. We probably had about 7 different routes. So in the last year, we said, OK, we're going to have a single front door. It's actually going to consider all topics and all products. And it's going to review those to ensure that when we publish, we're publishing on what matters most to the system. So it's going to prioritise those. And I think it's really interesting because everything will come into that prioritisation board, internally, externally, single front door on that website. And then what comes out of that will very much feed into what Stuart just mentioned in terms of that rules-based pathway for medtech. So I thought that was a really interesting link there when Stuart mentioned that. Just something else on this slide would be the EVA, those early value assessments. Next slide, please. And again, making sure that things are useful and usable. I might just pull out the case studies, so the work that we're doing on some of those. It's another big plug for that. I was going to highlight that incorporation of the drugs, the technology appraisals into guidelines. I mentioned that a little bit before, and I've chosen incorporation because at the moment what we're doing is we're just listing the drugs that are covered in that guideline. So those two things sit together. What we haven't done is integrated them to say at this stage you would use this drug, and then this one as a second choice, this one as a third choice. So we haven't ordered them, we've just grouped them in there, but we will look to order them to make that helpful in the system. We just haven't done that yet. If people haven't come across that yet, I think we've started with the obesity guideline and we've started to put those in, and as we publish, we'll be doing that moving forward. I suppose we'll get to the back catalogue eventually, but it's a start, and I think that's proved helpful. And the 4th slide, please, Marina, just on that. And again, what I'll pull out is a data directory in terms of what's happening in the system and us monitoring that. So that's that uptake and that sort of measurement. I had a recent example that was just mentioned to me yesterday, the 10-week booking appointment with pregnancy. And we've got a huge amount of data on that now. It's our first recommendation in our antenatal guideline about having that 10-week appointment. The evidence says that that time frame in terms of 10 weeks is very important. And what we can see is at a provider level, some organisations in the country are hitting that over 80% and some are only doing 18%. So we're having to understand that a little bit more to see how we can support that implementation. You know, we haven't broken it down yet in terms of ethnicity, socioeconomic deprivation, perhaps number of pregnancies. You know, there's a few things to look at there, but I thought that was very interesting, and that might be an element that we approach organisations for in the future to say, you know, we've seen some data, how can we help? Lovely. And then changing tack very slightly with the next slide, Marina. Great. Just a screenshot. The baseline assessment template now has what the red box highlights as update information. And if you click on that, it will give you the changes that we made. Some recommendations have been deleted. Some recommendations have changed their recommendation number. So we feel that would be helpful with some of the feedback that we had quite a lot previously. Any other changes that you want to stuff, please do say. You know, we do get there eventually, and we are really keen to hear from people. Brilliant. Next slide, please. I'm almost there. So these late stage assessments, I thought this was really interesting. Basically tasked by the Department of Health and Social Care. What's high annual cost? What's an existing procurement framework? Well, what's got price variation in the market? And what has led to some of these things having increased costs over time because there's been very slight change in the product. So we've been asked to look at those. On the right hand side, I've given the examples of what will be the pilot ones that we're starting at. You can see that some of them, you know, are continence pads, you know, beds, slide sheets. You know, there were things that were real surprises to me, and I thought, yeah, okay. So what will come out of that will be the review of the different types of things people are using that sits within that topic, what would be value for money, what actually would be a steer in terms if you are looking to make some cost saving or improvement there. So watch this space for them coming out, and as far as I'm aware, there's been nothing out just yet. Next slide, please. Great, I mentioned about guidance wording. What we're trying to do is make the wording the same across our different products. We do say quite a range of things, but we're going to try and say can be used during the evidence generation period. So that's for these early value assessments. More research is needed, should not be used. So we're going to try and steer away from other stuff, try and be very specific in terms of what we get, and we think that that will be helpful. We did a nice snap survey on that. So again, if you took part in any of that, thank you very much. Brilliant. The next 4 slides really talk about that query in terms of the paediatric early warning score. There's some really valuable information on this. I can see you, Vicky, and I know how we are for time. And I'm just wondering, can you give me a nod if you do want me to go through this in detail, or if you just want me to make these slides available?
It might be good just to have a couple of minutes on the pews, because I know that there will be people that provide paediatric services will be busy implementing the pews, and there's obviously concern you won't be compliant with nice guidance. So it might be worth just a couple of minutes covering it, Jo.
I'll try and be really, really succinct with that then. Okay. So if we had a query to say that, you know, when everybody adopts this, you know, they won't be in line with NICE. NICE has got the sepsis guideline, and we are working on a series of updates for those. There's details about sort of what sparked that, but the update from January only looked at the element for the over 16s in an acute hospital or mental health setting. So often when we do an update, we're not looking at all the criteria that might be covered with that. We left previous high risk, moderate risk criteria for all patients in the community and general practice settings. We didn't change the advice for people aged less than 16, nor people who have or been recently pregnant, keeping that high risk, moderate criteria. If that, so, you know, the changes that we made only applied to a small cohort there. So it's just to be aware of that. And we're doing various different updates. So a slight update that we did might have been because we were publishing the meningitis guideline. And again, that didn't affect the risk assessment that we were going to do with that. Let's skip through the next slide and see if there's anything I want to pull off that, please, in terms of the pews. Yeah, currently the guideline committee is reviewing recommendations for people covered by that news too in those areas. Doesn't include children, and we're wondering if it might, and we're asking the committee about that, but we haven't heard back on that. So after the latest review that we're doing, and we're working through these, then NICE will consider reviewing the use of pews and the maternity equivalent of that, making recommendations on them in the guideline. So it's not going to do it until it's done these updates. That's likely to be a bit of an issue with us not aligning possibly until 2026. You know what we're like with our time frames. Next slide, please. We know that the pews was only released in November for use on acute paediatric wards. There's not a version available for the ED, the emergency department, mental health settings or the community. From a NICE perspective, we think it'd be premature for NICE to consider pews at the moment, given that we would need to go back and repeat that process for those other areas. There's not a lot of high quality evidence on its use for the type that NICE would normally accept. But we do aim to be in line with that nationally. It will take us time and there's further work to be done. And the last slide in that series, brilliant. Regarding what trusts should do, and I get asked that a lot, it's often a local decision in this scenario. So it's only available at the moment for acute inpatient situations. Some trusts are going to struggle if there's a different one for ED or the wards. Some trusts are adapting that nationally for their local use in their emergency department. There is a lot of information on the Futures platform, and I've put a little link on there for something that was highlighted that you can search for to read a little bit more on that, or signpost others too if they ask this question. And we know that there might be concern about NICE not being in line, but what we would say, it would be reasonable for organisations to argue that they are following the recognised guidance that's come from these national bodies, the Academy of the Research Colleges and NHS England in the interim. Brilliant, hope that's helpful. The last slide is about the guidelines that's coming up. I haven't got anything particular to highlight there except the fact that there's plenty of TAs. I haven't listed the drugs there, but there isn't any quality standards. And the slide after that is about staying up to date, registering for our newsletter, my contact details. And that's brilliant. Thanks for that.
Excellent, Jo. You took us nicely through everything there and brought it in on time. That was really, really useful. And thanks for covering the pews, because I know those that do have paediatric services will be thinking, what do you do, Royal College? Nice. What's the ask? So, and ultimately it's about your organisation making the right decision for your patients, isn't it? So lovely. Have we got any questions for Jo?
There was just a little bit of a discussion in the chat about the baseline assessment templates and a comment about NC-POD. Helen Way, don't know if you want to bring yourself off mute or...
Hi there. I don't know if you can...
Yeah, we can hear you.
You can hear me, that's fine. I don't think my camera's working. I have a lot of pushback around the baseline assessment tools. And I guess one of the things that I was wondering is whether they could be filtered, because I know that the baselines often they're relevant to more than one area. So it could be that the healthcare, there could be some social care element in there, there could be something that commissioners would fill in, and whether there's a way of just filtering that really quickly for our staff so that they're just looking at the healthcare information.
I think that's an excellent comment. I will take that back. When I was at one of my local network meetings, somebody had said that they've actually put the baseline assessment template onto MS Teams, and they've invited the groups that they can just fill out the relevant sections to them, but it's knowing what section's relevant to them, isn't it? So I totally take on board your point. We should be looking next about how people can filter that easily.
That'd be great, thank you.
Okay, Sarah next, and then Etienne, I think.
Thanks, Marina. Thanks, Jo. Really helpful to receive the update. I do just have to say, wow, that is a lot of high level and very detailed information. And for me and to Vicky and the NQICAN team, I just want to say, can we look at how do we distill the updates from the NICE team into how practically folk within the NQICAN community need the information? And can we do deep dives, like you've just done a deep dive on pews, a bit of a response on the NICE baseline assessment, just so that we can really focus on the purpose of what information we're receiving and how we can practically use it, because we want folk to practically be able to go back to their organisation, go back to their team and really be able to do something with the info. That's point number one, and I will be brief, Vicky, because I know there's limited time. So what does it mean for folks? Can we do a deep dive? I'm driven by impact and implementation, so I oversee innovation, I oversee research, commercialisation and IP in NHS Dorset, so I'm the lead for the Dorset Innovation Hub. And time again, we are questioned on value with regards to work activity we're doing. So when you started talking about implementation reviews, I was thinking about there's always going to be new evidence. You were talking about updating a lot of the NICE guidance, which is great to see, but there's this plethora, and Vicky alluded to it just now as well, of different evidences coming out. There's limited capacity, and what we teach is you know, doing a smaller number of projects and doing them really well. We're ultimately looking at implementation within an organisation, and how can we really focus on that? So I just wonder if that plea could go back to NICE. We know we need to respond to evidence, we need to update evidence, but we also need to implement this within our organisations. And to do that with a big national audit programme, with a local priority programme, we have to look at what are the priorities. So could NICE look at, there's all this evidence out, there's this new and updated NICE guidance, these are the priorities we feel if you are an X provider, etc., because there's so much, there's a real danger of it being a tick box and focus saying they're compliant or whatever wording is used, but are they really? And when we look at CQC and all the evidences, when we look at clinical audit tools, how do we really say something's implemented and that that's made an impact positively for outcomes and experience for our population? I'm glad to get a couple of claps because, sorry, I'm putting myself on the naughty step for saying so much. Over to you, Vicky. Jo, that's said in a constructive way, and I'm happy to catch up and have a further conversation if it's helpful.
Let's do that, Sarah. Lovely, thank you.
You put that very eloquently. It was good. It was quite powerful what you just said, Sia.
And we've just got one more from Etienne.
Oh, yes. Thank you, Jo. That was wonderful. So when are we looking at starting with this new BAT form?
So the screenshot that I showed is because that is available on that guideline in terms of the tools and resources. We've just looked at some of the mental health ones and we've just started with those. So that was CG158 as an example. So we've probably done about 3 or 4. And we've just started that, so it's hot off the press, but that's the direction of travel for those. So we will start to do those as we publish.
Okay.
As updates are made.
Thank you.
Thanks, Jo. That was excellent. It's good to have the update. I know we've had a couple of queries about accessing the slides and recorded in the chat, so obviously we'll make those available as usual. Have we missed anything else in the chat, Marina? I'm just scrolling up.
I think I think we've got it all.
Yeah, that's good. That's excellent. Thank you. So I suppose we've literally got 2 minutes to go. Has anybody got any other questions that they want to pose whilst we're all here together?
Hello, Vicky. I think we missed that one on the fact that some of the national reports published do not have recommendations. It's good to compare the data, the local data, with regional data, national data sometimes, but not all the reports capture recommendations, I think.
Yeah, I'm just scrolling back up quickly, Etienne. I think did you put AKI, the AKI one?
Yeah,
was it that was in there, wasn't it? Which obviously isn't a HQIP NACAPOP funded one. I think that one's on the quality accounts, isn't it? And it's part of the renal registry, the AKI one, isn't it? So it's yeah, let's get the thread going on the NHS Futures platform, because the National Clinical Audit providers should be liaising with us on there, and we can start to say what we're going to find useful and what we're not. The difference between the NACAPOP and the other quality accounts topics that aren't NACAPOP is that those other topics that go on don't have that whole commissioning contract that the NACAPOP do with HQIP, and obviously I'll let HQIP come in if they need to add anything else onto it. And obviously there's some specific reporting requirements in the NACAPOP contracts of what they need to produce in terms of recommendations. We don't have that in place for those other quality account topics, and I know we've fed that back up through the HQIP and the NHS England route before around concerns around the quality of the other topics that are on the quality accounts list that aren't NACAPOP, and we can continue to do that. But let's get those discussions going, because we're going to capture those concerns from everybody around those other national clinical audits that we can work with the providers on, but also NHS England in terms of that quality accounts list being approved each year. Because you're right, it's in the NHS standard contract that we will participate in all the quality accounts topics, and therefore participation is about then taking forward those improvements for our patient groups. It's not just about putting data in. So
Thank you.
And then you've got Zoe.
Yes, sorry, a bit of a delay on there while I found my microphone. I'm relatively new to these meetings, having taken the Yearn chair last year, and it's just a bit of comment really to say that the more I attend, the more I get out of them, and the more I feed back to the staff. And I do find sometimes that I come and it's like, what about this and what about that? And it can sound quite negative sometimes, but it's not what I'm doing. I'm using it as a forum to feedback. But yeah, that's it's more of a positive comment of the forum and how it's being used. And I'm getting a lot out of it. And I hope that other people are starting to do that as well. And for colleagues that are on here that are part of Yorkshire and Humber, come along to the network. It's next week. I've put my email in there. We've started getting some really frequent flyers that are speaking up, and we're starting to talk to each other a lot more outside of the meetings as well. So come along. Anyway, thank you, everybody.
Thanks, Zoe. That's nice feedback to hear, actually. And this is the whole point, even with the open meeting, it is networking, isn't it? It's sharing and learning together alongside the regional networks as well, and obviously the platforms that we've got online as well. So yeah, it's nice to hear your feedback. And that's the whole point, that we're all bringing those questions and queries and challenges into this meeting, where we've got additional speakers here that can help us make things easier back in our own organisations. Lovely. Right, that's brilliant. Not seeing any further hands, and we're 2 minutes past 12. So thank you so much to everybody that's joined us today. Please do take those key points back to your organisation, and obviously once the slide pack and recordings available, we'll let you know, so you can share that with your teams as well and your colleagues. And obviously we encourage you to get in touch with those local regional network chairs. Visit our NQICAN website to find out who you need to get in contact with locally, or drop us an email to the nqi.can1@nhs.net email inbox if you want to know who your local chairs are, so we can put you in touch with them. So hopefully you'll have the rest of your day will be good for you, and we look forward to networking with you more during Clinical Audit Awareness Week on the 24th to the 28th of June as well. So look after yourselves, and we'll speak to you soon.
Take care.
Bye. Thank you. Thanks, everyone.
Stop the recording there, Vicky.
Okay. Thanks, Marina. That'd be great.